every system, every war. Lives are shaped by what's ignored, but change is rising, bold and clear. A new kind of leadership is here. Not just compliance, not just form, but systems built to withstand the storm.
Enhance patient safety, and become agents of change within our healthcare system. To every participant, congratulations on reaching this milestone. Developing a quality improvement project requires more than academic knowledge. It demands curiosity, problem solving, evidence-based thinking, and a genuine desire to make healthcare quality better. Regardless of today's outcome, each of you has already taken an important step towards becoming a healthcare leader capable of delivering meaningful change. As we begin, I would like to remind everyone of a few important guidelines. Please ensure you adhere to allocated presentation time. Presenters should keep their cameras and microphones on throughout their presentation unless instructed otherwise. Speak clearly, confidently, and professionally. Participants and audience members who are not presenting should kindly mute their mic to minimize distraction. Most importantly, let's encourage one another. Every presenter deserves our respect, attention, and support. So everyone joining us today, thank you for being part of this memorable occasion. Your participation, engagement, and votes helps make this event meaningful and impactful. Without further delay, let us begin. Our first presenter is Nuruddin Miriam. Nuruddin Miriam, are you there?
Yes, sir. Good evening, sir.
Good evening. Thank you for joining us. Can you share your slide?
Yes, you are.
Proceed.
Okay, thank you, sir. A woman leaves UITH. No one told her which bleeding is normal. No one told her which bleeding is normal. A few weeks later, she develops fever, foul discharge, severe headache. She is terrified. If she had known the danger signs, she would have come back immediately. This is the problem my quality improvement project is designed to solve. Good evening, everyone. My name is Nasruddin Mariam, a 200 level medical student at the University of Ilorin. My quality improvement project focuses on a critical life-saving issue, ensuring that every mother leaving the hospital knows the danger sign that could save their lives. So what problem am I addressing? Let me show you the data point. Less than 30% of mothers can name more than 3 danger signs at discharge. I observed this baseline when I asked postpartum mothers to mention 3 or more danger signs at postpartum. 7 out of 10 mothers could name this danger sign. Think about that. Data point 2. Approximately 20% of global maternal death occurs in Nigeria, and many is in the postpartum period. Data point 3, 80% of these adverse outcomes are considered preventable with timely recognition and action. This means this does not have to happen. Mothers are not dying because they are careless or negligent. They are dying because no one reliably told them what to watch for. The root cause is clear. There is no standardized counseling protocol, no feedback, no verification. I would like to emphasize this is a system failure, not a staff failure. Our nurses and doctors are hardworking and dedicated, but there is no system that is set to ensure counseling happens reliably. So how do we solve this systematically? I've designed a quality improvement framework with 6 components and 1 improvement. The problem, who is affected, where and why it matters, and the aim is going to talk about what improved, by how much, by when. Then the indicator, how we measure the progress. The change idea, the first small thing that I tested for. Then the PDSA plan, who does what, when and where. Then in the balancing measure, I'm talking about the side effects. The aim and indicator. The aim was to actually increase the proportion of postpartum mothers who can correctly identify at least 3 danger signs using feedback from less than 30% to greater than 70% within 30 days at the postnatal ward. And the indicator was that is the process that was measured. Percent of discharged mothers achieving feedback pass was greater than 3 danger signs, and it was named correctly. Using the SMART criteria, it was specific. We used the feedback to teach about the danger signs that they could watch for. It was measurable, we tally it daily. Achievable, 70% is actually realistic, relevant to reduce maternal death, time bound 30 days. The change idea, structured 5 minutes postnatal discharge counseling using the feedback method. How it works, a student delivers 5 minutes structured counseling at bedside using danger signs card, and the card is bilingual. We use plain English, then Yoruba with simple pictogram for mothers that don't understand English, then Yoruba, and with simple pictogram, at least they can have an insight on what we're talking about. Then the feedback, in your own words, what signs should bring you back. Mothers who do not pass get a brief explanation and is asked again. This card is given to the mother to take home as a reference. Why the 7 danger signs? What are the 7 danger signs on the card? Heavy or abnormal vaginal bleeding. This is actually a sign of postpartum hemorrhage. When there is fever or there is foul smelling discharge, it's actually a sign of infection, could be uterine infection. When there is severe headache or blood vision, or when there is convulsion or fit, this is actually a maternal seizure that is related to eclampsia. When there is difficulty breathing, it could be due to pulmonary embolism or heart failure. When the newborn is not feeding or not breathing well, it could be due to neonatal emergency. When there is swelling of the face, the hand or leg, it could be due to preeclampsia or eclampsia. Why the feedback? The JCI endorsed that feedback actually confirmed genuine comprehension, not passive receipt of information. The PDSA plan was the plan was to design danger sign card using Yoruba, English, and we create paper tally sheets. We define the pass and the fail criteria, then predicting the 70% pass rate by week 4. The do was to cancel all discharged mothers across 5 sessions or weeks for 4 weeks. Then we record the pass and fail daily. 2 STEM participate. No clinical protocol was altered. Then the study was to calculate the weekly pass rate. We plot a run chart, then note the barriers. Is it language barrier, time, and word traffic? Then we compare week 1 versus the week 4 trend. The ask was to actually, at week 5, if greater than or equals to 70% was met, we need to recommend the adoption to the ward team. But if it was partially met, we had to adapt the card or the timing. It was not met, we had to redesign and plan cycle 2. The timeline was actually week 1 was to prepare plus pilot, then week 2 to 4 was full implementation, week 5 was review and recommendation. The balancing measure and the quality dimension. Quality improvement is not just about hitting a target. We also have to guide against unintended harm. The average time that was added per discharge, we targeted less than 10 minutes and it was monitored weekly in 10 patient random sample. Using the STEP alignment, it was safe as the women were equipped to recognize it was timely, counseling at the point of discharge, effective, feedback is evidence-based, efficient, it was 5 minutes, 0 budget, and it was student-led, equitable, every mother regardless of their status whether you are rich, you are poor. And it was also patient-centered in a language verified by her. From a paper card today to a digital safety net tomorrow. We started from paper, then to a bedside talk, then to the digital transformation tool. Using the mobile health scale-up, WhatsApp or SMS danger sign reminder was sent to mother 48 to 72 hours post-discharge, and this reinforces in-person counseling at near zero cost. The digital data collection, paper tally was migrated to Kobo toolbox, Google form, then it auto-generates the run chart, it eliminates the calculation error. The electronic health record integration, discharge counseling completion plus the teachback pass or fail documented in the hospital information scheme. This enable population level quality dashboard. The student test that was applied to the mobile health extension. It was safer, it was easier, better data and privacy, it was consent needed. The equity gap was that patients without phone need alternative. So let me summarize the project in one table. The problem: most mothers at UIT postnatal ward discharged without knowing greater than 3 danger signs. The baseline was less than 30. The aim was to increase stitch-back pass rate to greater than 70% within 30 days at UIT postnatal ward. The indicator was percent discharged mothers passing stitch-back. Greater than 3 danger signs was named and it was measured daily. The change idea: structured 5-minute counseling with bilingual danger signs card plus stitch-back verification. The PDSA plan was 4-week cycle, and the balancing measure was average time that was added to discharge. Every postpartum mother leaving UIT deserves to know the danger signs that could save her life. Thank you.
Thank you for that wonderful presentation. It was timely and you make judicious of your time. Over to you, sir, Doctor.
Thank you.
Thank you so much, Miriam. I love the angle you came in through, and of course, anything that has to do with childbirth, anything postpartum, of course, the emotional connection for majority of your audience is there already. So, and great job, 200 level medical students. That's a great presentation. Well done. It's a topic that has to be there to everybody's at anyway. And of course, even globally. So I love that angle. The only thing I'll just say is it seems like it's an already done project. From some of it might be the way you presented it, anyways. But overall, well done. Thank you.
Thank you so much, Ma. Thank you, sir.
Yeah, I'm struggling to believe that you're in 200 level. So are you actually in 200 level?
Yes, sir.
What level are you?
Sir,
What level are you?
200 level
Do you have a first
medicine,
degree?
sir. No, sir.
Okay, that's a great job, right? For you to even think about postpartum infection or anything related to postpartum at 200 level is a significant one. And of course, anyone in 500, 600 will agree with me, what I'm trying to say. So that's a great one. And you show a lot of good mastery of the slide. Of course, I see you're presenting from a mobile phone, right? So there was a bit of a struggle with the size and this thing. Um, One important thing is, and maybe this goes to everyone, this goes to everyone. When in the selection of your topic, you must also think about topics that will resonate with people, and that would have this emotional connection. Anything maternal and child health has a very strong public health resonance effect once you bring it up. If you have any woman on the panel, you automatically win their heart. If you have a man on the panel who has a wife and they've given birth, you automatically win their heart. So it gives you a strong distance. I remember one of the Camtech project I won $1,000 on many years ago. It was also on stubbornly high maternal mortality rates in Kwara State. So stuffs like that really, and it will give you a lot of points in the scoring when they talk about the significance of the problem. Something closer to it would be something like the emergency presentation last week as well. If you present stuffs that are related to emergency department where they know that the consequence is people dying almost immediately once something does not work, it gets everybody listening. And I'm just trying to talk about this generally, but great job. Thank you.
Sir. Thank you very much, sir. Thanks.
Sorry, quick one before you jump to the next person. Is there a tool that can, even if it's just a small application, that models can download? It can be AI empowered and can give models all these life saving skills. If anything is unclear to them, they can ask questions from their caregiver. Do you know of any tool like that that is already existing?
No, sir, but I can actually think of a mobile health tool or the Kobo toolbox.
Yeah, mobile health application. So I'm talking about an application like that that will be on the mobile. Yeah, because I'm working with some team here in the United States, but this one is more pediatric related. We wanted to help mothers who had polypharmacy. When you have your child have more than 5 medications and they want to discharge you home, we wanted to have a tool that can help the mothers reduce medication error, because imagine if you have 5 medications to give the child, how do you even manage the timing, the dosing, and all those things? So these are ideas that are just out there. I was just asking if you know of any tool like that. Thank you.
Thank you very much, sir.
Yeah, but great presentation, Miriam. Well done.
Thank you, sir.
All right, Femi, who goes next?
Thank you, sir. Thank you, Ma, for that wonderful comments. Our next presenter is Atilayo Aro Ajibo. Are you there?
Good evening, everyone. My name is Aro Ajibo Atilayo David, a fourth-year medical student at the University of Ilorin. My quality improvement project for the health quality patient safety digital transformation quote one is titled the Fresh Eyes Campaign, optimizing admission clinical handovers via student-led SBAR peer feedback loop. But before I start, I would like you to meet Mr. Ibrahim. So Mr. Ibrahim is a patient at the General Medical Ward, UITH. So Mr. Ibrahim has been admitted, presenting with a dizzying, incredibly complex array of symptoms. The admitting physician on duty is a brilliant perfectionist, determined to capture every nuance. They spend 40 minutes drafting a flawless 3-page admission. It is truly a masterpiece of clinical documentation, impeccably thorough, beautifully written, with not a single detail left out. Tucked elegantly away on page 2, right in the middle of a dense paragraph, detailing his past medical history. The doctor clearly ties the word. Patient has a life-threatening allergy to penicillin. Fast forward to 8 a.m. The morning shift physician takes over. They are deeply responsible and highly competent. They don't call corners. In fact, they actually sit down and read Mr. Ibrahim's file from start to finish. But here is the catch. The human brain has limits. As the physician reads the file, the world around them becomes a chaotic battlefield of distractions. Monitors are constantly beeping, nurses are asking for urgent discharge orders, and 20 other critically ill patients are waiting for attention. Under this crushing cognitive load, Mr. Ibrahim's beautifully written 3-page notes transforms into a flat, overwhelming wall of text. That life-threatening allergy hidden on page 2 doesn't flash red. It doesn't scream for attention. It simply sits there, quietly disguised as another line of text. The physician closes the file, completely unaware that they just looked directly at the clinical landmine and missed it entirely. Minutes later, they prescribed fast-acting penicillin-based antibiotic for Mr. Ibrahim. It is only by sheer terrifying luck, a sharp bedside nurse passing with a syringe in hand, that a fatal anaphylactic shock is avoided at 11:30. Now, why am I telling you about Mr. Ibrahim? Because this system didn't fail because the file wasn't, or because the physician was busy. The system failed because a standard medical chart cannot prioritize information. It treats a minor surgical history and a fatal drug allergy with the exact same visual weight. This is precisely why I developed Fresh Eyes campaign, the SBR framework. The SBR framework isn't meant to replace the chart or the medical folder. It acts as the signal in the noise. It forces us to extract the most vital transitions of care and say out loud under background, Mr. Ibrahim has a fatal allergen. Good evening once again. I've just read to you a story of a young man admitted to the University of Iran Teaching Hospital. He's been managed for a condition called infective endocarditis, but he has an allergy to penicillin-based antibiotics, which was recorded in his medical folder, but was just written as another line of story, past medical history. He doesn't scream, he sits there. The doctor, due to problems due to unstructured clinical handovers, high cognitive load, missed contingency plans, data omissions, delayed diagnostics, they all compound to cause bigger problems. According to the Swiss skills model, it says bad outcomes rarely come from one big mistake. They happen when multiple small failures line up. So according to Jeremy Owak, he published in 2010, he says 1 in 10 patients are harmed in healthcare. More than 3 million deaths occur annually worldwide due to patient safety incidents. Roger A. Ettinger also published in 2021. He says in routine healthcare practice, appropriate handover of patients from health professionals across shift regimes is crucial to improve care continuity and outcome. Hence the need for SBAR campaign. Communication failure during transitions, missing critical lab results, lack of structured updates, they all cause increased clinical uncertainty and elevated patient safety. Information loss then cascades into clinical risk every transition point. The aim of this project aims to optimize post-admission clinical handovers on general medical ward GIT by increasing full compliance with SBR framework during money handovers from an estimated baseline of 50% to a verified 90% among rotating students and junior interns within the next 30 days. Someone might be puzzled why optimizing post-admission from a 40% baseline to a 90% budget. The project ought to be innovative, yes. The reason for the estimated 40% put there is the comparison with systems that are in place during clinical handovers presently at the General Medical Board, which is via the electronic health records, the physical folders. And then why 90% targets and 100% target? According to the Institute of Healthcare Improvement Methodologies, it says that system designs reliability for a system to achieve 90% system reliability. Structures such as staff training, use of cards, use of more data encryption, posters can help achieve 90% success. If we request for more, say 95%, 99%, we need integration of high technical structures, such as hardwired system constants, electronic health records. So next slide. SBR, what is SBR? SBR is a pocket-sized sheet that has 4 components. S stands for situation, B stands for background, A stands for assessment, R for recommendation. The S has some components, which are the patient identity, the patient's hospital number, the patient's relevant data that can be used to identify the patient's ward number, the patient's bed number, location, current concern, vital signs. Why B background? It highlights relevant past medical history, such as the penicillin allergy Mr. Ibrahim has, the medications, and then the recent investigations that have been done, such as ultrasound and all other relevant clinical investigations that will be carried out on a patient, pending the time the patient gets a comprehensive treatment. A, assessment. Assessment shows the clinical impression, the working diagnosis, the proposed and severity of the ailment, while recommendation shows the proposed plan, the suggestions by the current team for the next team. All right. How do you measure the success of the SPAR pocket size for sheet? The primary outcome indicator is number of patients handovers containing all 4 SBAR components divided by the number of total patients handovers observed, multiplied by 100%. So what does the process measure? The process measures SBAR pocket cards printed and distributed, and students onboarding completion rates. So balancing measure, same time while we aim to achieve a post-admission, a successful post-admission handover, we also have to look out for some factors, which are increase in total, if there's, all right. So the PDSC cycle 1, days 1, the prototype testing. So we administer the cards to students to rotating interns on the board. The 6 to 5 expanded testing. We monitor the balancing measures, workflow verification, feedback
Disconnect
integration.
yourself from your phone.
My phone
I
is
can
not
see that you are connected with your phone
Allow
and
him
your
to
HP.
continue. I've muted the other part. Allow him continue.
All
Go
right,
ahead,
sir.
please.
Thank you, sir. Expanded testing, that's cycle 2. It monitors balancing measures, workflow verification, peer feedback integration, and duration tracking initiated. This 15, the full implementation, as the full-scale deployment, student and intern adoption, sustained compliance monitoring, and then final data collection. So designing for humans, this chart shows the just culture principle, which highlights that we design for humans, we don't blame humans. Cognitive fatigue, latent system vulnerabilities, they could cause increased harm or pose danger to patients. However, this SBR2 allows for structured communication, safety-centered design, and just control principles. The SBR pocket sheet acts as a cognitive support layer, reducing reliance on memory and enabling structured communication, even under fatigue and time pressure. Structured SBR handovers would not increase toxic and quality. So small tools, saver systems, better care. Structured communication improves patient safety. Low-cost interventions can create major system impact. Student-led innovation can strengthen healthcare systems. Sustainable and scalable across clinical settings. Thank you very much. So my recommendation for the SBAR, I would push for its integration into the UITH patient monitoring system, which doesn't strike out the use of the conventional folder and the AHR. This just helps to highlight the concerns, patient concerns, so as to help them get a comprehensive um, treatment and also to improve health outcomes. Thank you very much, sir.
Thank you for that presentation.
Thank you, sir.
Yeah, thank you, Atilaya, for the presentation. Your topic, well, it's relevant. I won't discountenance that, but I wish it was strong enough than what you have currently. I'm sorry, I like to say it as it is. Then I think you might need a little bit more work with your presentation. In as much as I love the fact that you wanted to tell a story, it was obvious you were reading. There's actually a way. Can you mute Atilaya generally for now? Okay, so there's a way you can actually have your speaker notes on your PowerPoint slide that it won't be so obvious like that you are reading, especially if we are not speaking, if you are speaking on camera. So you'll be looking at your screen, so it will be as if you are speaking from your heart, especially because you are telling a story. So it makes it more relatable as against I could see that you were reading from a book, though you also said it that you were reading, but then what makes it fun, what makes it relatable, what makes it memorable is the fact that you're speaking like you actually knew who Mr. Ibrahim was and not just somebody that you heard the story or you are reading a story as you're presenting. Overall, well done.
Yeah, I think when you started, there was an Fuhad joined, right? Femi. I don't know if he's still on. That's Fuad Damilola from the HQPSTP first cohort. In case he joins back, I just wanted you to pay attention. Okay, so I really want to encourage you, and I want you to understand that the topic you took looked a little bit maybe complex. Communication failure is a big issue, and it's more than just S-bar communication model. I'm sure you know there are also other ones like SOAP method and other methods to manage communication. The struggle I am having, aside from the technical glitches you had experienced, the struggle I'm having is one, your own core understanding of the concept. That's one. To also understand that S-bar is just a communication framework, not necessarily something that has to be like a printed card that has to be in someone's pocket. That's two. And then S-bar is used for different forms of assessment beyond even communication. We use it for clinical assessments too. Of course, maybe by the time you do medicine, surgery, you would understand that they use it generally for quick, rapid clinical assessment as well. Now, having said that, the final part for me is I'm not able to wrap my mind exactly around the intervention. So if you have a single slide and you have 30 seconds now, can you tell me exactly what your intervention will solve and what exactly you're doing? That's actually the part that is missing from, because I'm not able to even score that part for you. 30 seconds.
Okay, sir. So can I share my slide again?
Maybe just explain it. Or if you have a slide that can capture it, yeah, that's great. Quickly, I would appreciate it because it will help me see too. If you can just go straight to that slide that captures the exact intervention that you're bringing up.
Okay. Can you see the
So
slide,
the
sir?
intervention is actually the pocket sheet that has the S-bar acronym that tells the physician or the nurses or the laboratory scientist that wants to hand over about the challenge or about the situation, the background, the assessment, and the recommendation. Is that it?
Yes, sir.
Okay, so we want to create a laminated pocket card but would it be on the bedside, or it will be in each practitioner's pocket, each clinician's pocket?
Okay, sir. I think the primary thing I drafted the project for
Okay.
is for it to be with the junior interns, the
Okay.
nurses that
Okay.
oversee the patients.
Okay.
But it has another advantage. According to a study I reviewed when I was preparing it,
Okay.
I found out that informed patients have better health outcomes. So, the conventional hospital folder isn't always accessible to patients, but SBR is accessible to patients. It's also written in simple terms patients can know and also speak up for themselves when they see a nurse come administer a drug. But it is primarily built, like the system is primarily built to help junior interns and nurses be a part of the treatment. So it is meant to be with the junior interns or the students, medical students.
Thank you so much. But I'll rephrase your intervention. You're speaking because you assume that every hospital will continue to use folder. I can make an application integrated with the last person's presentation that will do this S-bar analysis for a patient in simple layman language that they can understand. And that will be my tool that once a patient logs in, they can see their S-bar analysis this morning that the house officer just finished, that the nurse manager did, that the nurse intern did, and they can track if there's any improvement in what their assessment had been. Of course, a lot of things will remain the same, like working diagnosis, except stuff changes. And then the proposed plan too, they can also see it. And that because you said something that is significant. You said patients don't have access to that folder, but sometimes those folders are just left beside the patient on the table beside them, so they really do actually have physical access to it. It's just that policy wise or philosophically it's been made that they should not, which doesn't change anything. Normally in a transparent system, patients should know exactly what you're writing down. It's their life. One of the key things of the STEEP dimension of quality, the sixth dimension, is patient-centered care. So because this program is also integrated with digital transformation, I think it's more wiser for us to leapfrog from a pocket card to something that can be digitally enabled on a mobile phone, most importantly. But thank you so much for your presentation. I think I pick an idea from this now.
Thank you very much, sir.
Yeah.
I will work on all of the things you listed, sir.
All right. Great job.
Thank you, sir.
Well done. Yeah.
Thank you very much, sir. Thank you very much, sir. Our next presenter is Umar Amdalat. Testimony. Are you there?
Yes, I'm here, sir.
All right.
Yes, sir.
You
Thank you
can
very
open
much,
your
sir.
camera and share your slide.
Okay, sir. Good evening, everyone. Thank you very much for this opportunity. Good day, everyone. My name is Umar Amdalat Testimony, and today I'll be presenting a student-led quality improvement project titled Reducing Patient Identification Errors Before Sample Collection. And this project was inspired by The project was inspired by observations made during my clinical placement, where I noticed specimen collection was not always carried out consistently. Although it may seem like a small step. Sorry, this may seem like a small step. Errors at this point can result in mislabeled specimens. Mislabeled specimens, delayed diagnosis, repeat blood draws, unnecessary costs, and even
Sorry,
patient
one
harm.
one second. Testimony. Sorry, there is an X logo. If you look at the other side of the navigation, can you click on that X so that it closes that sidebar for you? The
Okay,
X,
sir.
and so you now have a full screen. The second thing is I don't
Okay.
have your.
Students in the University of Ibadan.
Okay.
Okay. So the aim of this project is to reduce patient identification errors from an estimated 12% to below 3% without increasing the time required for sample collection. And I made use of the fishbone analysis, and it identified the major contributing factors as reliance on visual recognition instead of verbal confirmation, and the absence of a mandatory verification step, communication gaps, busy word environment, and specimen labels being printed away from the bedside. So, to address these issues, the project applies the Donabedian model by improving the structure through bedside verification tools, strengthening the process by ensuring every patient is identified using two verbal identifiers, and ultimately improving the outcome by reducing specimen mislabeling. It also aligns with the 6 STEEP lens and lens dimensions of healthcare quality by making care safer, timely, effective, efficient, equitable, and patient centered. So, moving on from a patient centered perspective, the project recognizes the identification errors. The identification errors are as a result of system failures rather than individual negligence. And concepts such as near misses, human factors, the Swiss cheese model, and just culture all demonstrate the importance of redesigning the system instead of simply blaming healthcare workers. So my proposed intervention is simply straight to the point. It's a QR coded patient verification system where the patient's wristband is scanned before specimen collection. Okay, scanned before specimen collection, and the patient's name and date of birth are then confirmed verbally, and the specimen label is printed only after successful verification at the bedside. This intervention will be tested using a single PDSA cycle, and the progress will be monitored through verification, compliance, specimen mislabeling rates, repeat blood draws, and collective time to ensure that patient safety improves without compromising quality and efficiency. Furthermore, the projected results show a steady decline in mislabeling in mislabeling rates following implementation. And to sustain these improvements, the verification process will be incorporated into staff orientation, and it will be monitored regularly through quality dashboards assigned to a ward quality expert and integrated into hospital policy. So basically, it's a QR coded system of identifying patients at the bedside before taking their specimens to the lab for any of the tests. And in conclusion, this project demonstrates that a simple structured verification process can significantly reduce patient identification errors and improve patient safety. And it also reinforces that improving healthcare healthcare quality in our systems, our hospital systems, or in the general healthcare system comes from strengthening systems rather than relying solely on individuals to do the job. Thank you very much, sir.
Thank you for your presentation. Thank you. Thank you.
Thank you, sir.
Ma,
Yeah,
Mrs.
thank you so
Kolawole, ma.
much, testimony, for your presentation.
Thank you, ma'am.
So I love your topic, mislabeling and all of that. Just like the results relay that we had last week. I love the relevance, and you mentioned quite a lot of what's it called, framework. You mentioned the Donabedian and all of that, which shows you were actually listening. And of course, it's quite relatable. Presentation nice. It would have been very better if you have a PowerPoint slide. I'll say that, so that it
Okay.
doesn't look like an unfinished work. But presentation, it shows you know what you're doing, what you're saying, and thank you so much.
Thank you, ma.
All right, testimony. Sorry, I'm going to call you out a little bit. I just want to prepare your emotions for that. I hope you're ready.
Yes, I have.
All right. Which AI did you use to prepare this material?
Sir?
Which AI tool did you use to prepare this material?
Okay, I prepared the content myself, but the organizing was with Claudine.
Claude AI, right? Do
Yeah.
you know Claude could have done an excellent PowerPoint slide for you in less than 5 minutes?
Yes, the initial I have a PowerPoint slide, but I was told I would use a Word document. So I had it converted to a Word document, sir.
Who told you that? Sorry.
Uh, I was sent a message on Gmail, sir, my email
So
after submission.
there must have been a communication gap there. Every other person you had seen last, were you here last week?
Yes, sir.
And of course, you had seen people had joined earlier. You've not seen anyone use the Word document. You see, if you're going to do anything out of the box, you better be bringing something that is extraordinary. Do you understand? I salute your
Yes, sir.
courage for even having the composure to present the Word document. But if you're going to come and do something that is not the usual norm, it's better you bring something that is like way out of this world. That's what
Okay,
would
sir.
wow whoever is seeing what you're doing. But if you do something like this and you present a Word document where others had presented a PowerPoint, you had already set yourself up not so much for a good consideration. You have an excellent topic. This happens almost everywhere. The only challenge I have with the topic is that the topic has also been solved. It's a problem that has been solved. I'm sure you know that. Um, I, I think to a large extent in Nigeria, many hospitals should be using barcode. But even if they don't, I know in the developed nations, there is no way you go to any lab without having a barcode scan. Do you get it? It scans
Yes, sir.
and you have two-factor identifiers, like you said, date of birth, name, hospital number, and all those other identifiers. Here we use social security numbers and other things that they can use to identify you, your address, your driver's license number, and all those other factors. So you have a good project. The project had been solved globally. If you're going to implement it in African setting, it's going to cost more money, because what you're trying to do is you're trying to get the hospital to buy a barcode scanner all through. So I don't know, does UCH have a scanner already?
No, sir.
No.
We don't
So
have one here.
that would be an heavy project on the CMD if you want to give him that kind of a project. Do you understand the idea now?
Yes, sir.
And it's not something you can solve with a small PDSA. It's definitely not, because you really need a big project, a big budget to solve that kind of a problem for an hospital as big as UCH. For you to be able to get a barcode scanner, because you need a central memory system that the scanner will actually pull details from, and then you need a screen where it will render the details too. For verification and validation. So there's a lot that is integrated with that. One advantage that project has is it could help nursing, it could help pharmacy. So it's not only laboratory that it would help. It could help even other areas of the hospital. So, but great project. It's been solved in some climes. It's a heavily funded. It's a project that requires a heavy funding. You understand? Yeah.
Yes,
So,
sir.
but good attempt. Thank you for
Thank
showing.
you, sir.
Yeah. All right. Who's next?
Thank you, sir. Thank you, ma. To Amdala testimony, I want to correct that notion that you received an email regarding Word documents. The email you received was regarding, you did not submit the Word documents that details your quality improvement projects. You only submitted your PowerPoint there. So I asked you to submit the documents and your video because we were unable to access it. So take note of that. Nobody asks you to present through the Word documents.
Oh,
The
that must have
next,
been a misinterpretation on my part. Thank you, sir.
okay, all right, noted. Our next presenter is Ju Jedida Uzodima.
Good
Are you there?
evening. Yes,
All
I'm
right,
there.
good evening. All right,
Sorry, just a little
Please
correction. My name is
teach us.
Jedediah.
Thank you.
Yeah.
That's what I wanted to say. Teach us how to pronounce your name very well.
all right.
Yeah,
Sorry about that.
Jedediah. All right, I want to start sharing my screen. Okay. Imagine this scenarios: two patients and two outcomes. Mr. Paul, just before 11 p.m., he was rushed to the UITH emergency room after a motorcycle accident, and a severe traumatic brain injury was suspected. The diagnosis is already a race against time, but because of the improper management, the emergency kits, including the IV cannula and give inserts, monitor, and every other thing that is needed, they are not stocked at the bedside. So, because of this, the pharmacy is open all night, but his relatives are now sent out to go and get this um instrument. But as a result of that, because of the nature of his injury, his care was very, very delayed. Even sef the consumables were they were not stopped at the point of care. So this caused a delay in his treatment and a very poor prognosis. But look at another situation. On the same night in a different hospital, Miss Loretta was rushed to a different emergency, and she had a life-threatening obstetric emergency. But the nurse on duty this time reached out for a checklist, including every single thing that was needed. And within no time, the materials were already at her bedside. um there was no the time that was spent getting appropriate care was reduced, and eventually her prognosis became better. So my quality improvement project is centered around reducing treatment delay caused by out-of-pocket sourcing emergency consumables. My name is Jedediah Uzodima. I am a 500 level medical student of the University of Ilorin Teaching Hospital. So, a rough overview: basic emergency consumables, including as listed as seen, they are not frequently stopped at the point of care in UITH. Usually, the relatives of the patient, or the patient, if the patient is strong enough, has to go to the pharmacy, which is like a considerably not so close distance from the hospital. And this reflects a nationwide funding gap, because out of pocket spending accounts for 75% of healthcare expenditure in Nigeria. This project, however, does not aim to fix that gap, because it is beyond a student's scope. However, it looks for ways to reduce the risk with this problem. There are estimated 2 to 3 pharmacy trips per emergency. So, problem background, we'll talk about who, where, and why it matters. The patients with the emergencies, they are the ones that bear the risk of this. And yes, I observed this in my post now as a 500 level medical student. I even observed it in 400 level as well. And this matters because, as mentioned earlier, we need to find a solution to the fact that there is delay in care in accident cases. So this is a fishbone diagram illustrating the issue, just to give us an image to work with. So there is little systemic funding for emergency kits, which increases the process and workflow. Also, because of the fact that the healthcare professionals, maybe the doctors or the nurses, will have to talk to the patients. There are instances where the patients may have a language barrier. Maybe they speak Hausa or they speak Efik, and they are not able to translate it. So that one, they will not have to look for another translator again. Then eventually the whole environment it creates extra stress, ultimately leading to delay in emergency treatment. So aim statement: I intend to increase the delay time by 50% and reduce the average trip from 2 to 3 trips per case to at least one per case. The measurement plan, as stated here: primary measure is to eliminate the cumbersome process that is involved in identifying the emergency consumables, and then, um as mentioned earlier, to reduce the amount of trips in the A&E. So the change idea: a one-page checklist listing the items that are most commonly used for emergency presentation should be handed to the relatives at first as assessment, so that the items are purchased in one single trip rather than going back and forth. Um, our supporting step, brief we should brief, yes, the supporting step is to brief doctors and nurses to consolidate what is needed before the driver. So we have to oversee, we have to like check with doctors and nurses. I intend to check with doctors and nurses so that we'll have a very standard approved list rather than just repeating cases and also like accumulating costs, because sometimes some things might not be needed, but when we know the average things that are needed, including IV fluid, giving sets, syringes, sutures, gloves, plaster, and there are you tourniquets, methylated spirits, antibiotics in case of, even without infection, since it's an emergency we suspect infection. When this is standard, it will help, it will go a long way. Why this not something bitter? First and foremost, no hospital funding or permanent changes needed, because this is within a student scope, and it already uses the existing workforce, so it is low cost and fast, and it is fully reversible. And then like I said earlier, it fits into a student's timeline. So this is PDSA outline, the plan to have a baseline data collection and to draft a checklist with the residents so that it will be, and also get the word sign up. The do, that means we introduce the checklist as a first, at first for new admission. Then we'll now observe, track the delay and the trips. Then to study, to compare, we'll compare weekly changes as baseline, and then we'll guide, we'll take reviews from maybe informal staff or even the relatives. Their input, their feedback is needed for with this initiative. Then if improved, we should standardize the adoption, we should make it better. But if not, we can revise it and add signage. Balancing measures, relative are asked to buy items that end up used instead of unused. Then we can also check for extra staff time. That's one of the problems, extra staff time, and also um the checklist stands, I'm sorry, I'm finding it hard to read. It can read, the checklist reads as normalizing the cost rather than stopping a gap fix. So it can turn to redundant project if we're not careful. That's why we have to keep reviewing it so that we'll know, when the patient does not need suture, we now say suture, and then there's extra costs instead of trying to, so our expected costs, like I said, to reduce the trips from 2 to 3 trips per session to one, and to reduce the time at least by 50%. So next step, we'll hand up the list template and submit the results to the ward leadership, incorporate the checklist into admission, and assess performance for emergency and surgical cases. Then this data that we assess, we'll collect it, and we'll use the collectional delay and cost burden as an advocacy point in the hospital to fund or restock the highest frequency items. So once we see that this initiative has gained momentum, we can then appeal to the leadership of the emergency unit to consider funding this, at least even if they pay, maybe there is a system, maybe there is a place where the patients pay, since the hospital is not necessarily funding it, but let the items be pre laid down so that they don't have to walk up and down for cases where it may be in the evening that they come, or in the night. So this project, like every other project, is not perfect. There are limitations. For example, it does not address the root cause, like the underlying funding gap. um there can be observer bias. So sometimes different people may have different experiences with this. Recall bias, sometimes some relatives might forget on the way, maybe because of the nature, maybe they are tense because of the person they brought to the hospital is in critical condition, so there might be recall bias. And then stock out to the pharmacy close by may not be, may have run out of stock on some equipment. Then auto effects, because this is very much labor intensive, sometimes the staff may get tired eventually. So that's why we need to monitor and keep revising the project. All right, so in conclusion, this project is applies a structured evidence based approach to a well documented problem in Nigeria public tertiary care, which is the delay created when emergency consumables must be sourced out of pocket, rather than claiming to solve the funding gap, which is not realistic immediately. It targets a compounding process failure a student can feasibly test within one posting, consolidating what relatives are asked to buy into a single trip instead of several, and to get treatment started sooner. Thank you very much.
Thank you so much, Jedediah. Um, nice presentation. I'm just looking at the feasibility because just like you mentioned, you said labor intensive, and once you started, I started picking that labor intensivity. Because nobody wants to really take responsibility when it comes to things like that. Everybody wants to hands up, especially because human factor is already involved. If we don't have a standardized, let's say A and E pack, if we don't have that, if because case by case, I'm not a medical person, but at least from the little I know, cases differ. So are you talking about having a standardized pack, or they still have to confirm based on the issue on ground? Because they might be
Okay.
needing other things too. I just want to have a better understanding of that.
Okay, because it's something we'll have to revise with the doctors and the nurses first. In medicine, there's a saying that goes common things occur commonly. So based
Mm,
on the common emergency cases, we already have a standardized kit that will be there, and
okay.
if possible, when if the hospital management is able to fund it, we might have like maybe stock them close by to the hospital. Since the hospital management itself does not fund it, the out of pocket might not be solved, but at least the amount of trips will be solved because they can just get it close to the hospital when it's still in
Mm-hmm.
stock in the hospital. Just get it. Then for special cases, that's why we have to keep revising. For special cases, that's when we can now add the list. But like in order to save time, the common emergency cases which occur commonly, the standardized list will go a long way in saving time, because sometimes they'll be like, we forgot to buy plaster, this person forgot cotton wool and all that. So that's
That is
like
annoying.
exactly.
Yeah. Thank you so much. Now I get it. Thank you. Nice presentation. It shows that you have already seen this firsthand, and maybe somebody close, because that thing is really annoying. You go back, they say you need something. I'm just coming from that place, and that's why, especially for UITH, there's a common saying that when a relative goes to UITH with a sick person, the relative will end up being the sick person because of the back and forth.
It's really crazy,
So
man.
I get it. Thank you so much. It's actually relatable. Thanks.
Stop
Okay, man.
debranding my alma mater. So you cannot.
But I'm also University of Learning graduate now, even if it's not medicine. But then my mom worked for 35 years in that hospital, so I know what I'm saying.
All right. So good problem identification. In fact, excellent problem identified. Now, can I shock you? The solution to that problem is beyond even the CMD. That's actually the reality. We need a well-structured system that has to be federally supported to solve that problem. And that's one of the challenge that Nigeria runs a mixed economy. In the United States, where we run a capitalist economy, what happens is there's already what we call kits that are pre-packed by different companies. Do you understand? By different companies. So there's even competition amongst them to provide their kits into the surgical theater, A&E, OPD, everywhere. So they have all those pre-packed kits, and they even have bonuses that they give to hospitals, such that if you have a patient that is even indigent, they are not able to pay, you can pick out of the free ones to manage the patient and then later get reimbursed or get other things back. So that's why I said the problem is a problem that the Federal Ministry of Health really needs to, if we want to solve it, it has to come from the federal minister saying there is a plan for this. We need companies who would already pre-pack all these details, and then payment can be made easy. You can have a self-dispensing machine on the wall, in the emergency room, in every ICU, different places. People only need to swipe their card, press the pin code of what they need to pick, and the thing dispenses and you pick it and move on. In fact, here in the US, I once volunteered for an hospital many years ago. What they even do is that after a while, the ones that maybe the expiry date is getting close by, right? They quickly donate it freely so that they could use it in different procedures before the expiry date comes. So all these things are methods that can be used, but unfortunately, you have a pan-systemic problem. So even if you get to UCH, LUTH, everywhere, that's still the same problem you would identify. So my challenge with your selection is you saw a big problem, but PDSA cannot solve your big problem. Your big problem requires what we call maybe a trip model to solve. That's translating research into practice. And we have the 6E model. You could read about that. I love teaching that in the HQPSTP program, which was profounded by Pronovost et al. We use it in Johns Hopkins. So that's actually what you can use for that kind of level, because this level of project also requires a fractal solution. You need supply chain management at the federal level, at the hospital level, and also at the usage level, at the consumer level, because it could also shock you that some of your consultant could pack some of those kits and take it to their private hospital. So, and I'm not sorry to say this, these are practical realities that could happen. You will be so shocked that it would happen. A pharmacist can pack it and go and sell it in town. A nurse can pack it and go and use it in her own private practice, or even use it in her own home where she's managing patients. So just think about this problem at multiple level and think about solutions at multiple levels. So, and this is to everyone now. When you now have a big problem like this, if you want to really use PDSA, you may have to find a smallest chunk of a big problem and what you can quickly solve with PDSA that will really not require money. In most cases, that is what you can use a rapid cycle process like PDSA to quickly solve. But when you have a systemic problem that requires an hospital large distance, trust me, it's going to take a whole lot. If it was easy to solve, the CMD should have done something about it.
Yes, sir. Can I say something?
Yeah, please go ahead.
Okay, so that was why I focused mainly on like having it written down, because a lot of times when I'm on call in A&E,
Okay.
they will maybe the doctor on call might write just three items because of the rush of everything, and then they will not realize mid procedure that we need something else. So the relative will not have to go back again. That's why at least even if we can't even provide it, it's the first step I listed was to have that list drafted out for common emergencies, so that at least they can just easily just hand it. Once they assess that this is emergency, they just hand the list over to the patient or the relative, so that even if we're even going for, let it be once, at least let it just be once, first and foremost. At least that kind of helps a little bit.
Excellent. I can see some my wife writing this can be used as a PhD level project. I love the fact that you're thinking big though, which is great, right? Yeah, and so that's the job of the nursing system. They should have
Yes, sir.
everything clearly documented, and that's one of the things the kit does, because the kit had already studied all the procedures that are possible for any form of procedure in the A&E, and they already have a pre-packed kit for it, and they have a code for it. In fact, there are barcodes, everything. So once you show up and they know that this is what you're likely to get, they automatically just give you the code, just go and get it, and they bring it out. Now, another redesign to the process, just to manage our time, another redesign to the process would have been that the burden of getting it for accident and emergency should not have been on the patient or their relative. We have a law here we call the tort law, which takes care of you in the first 48 hours when you are in an emergency situation. That is actually where we should get to. I know the federal minister is working on a project, but the project involves just getting you to a facility and getting you taken care of. How well they have now designed it around consumable is what I'll probably talk to the Kwara State Director about. But I'm not sure it's well defined to that level as of the last time we spoke. But thank you for bringing it up. That's a good one.
Thank you, sir.
Yeah. All right, who's next?
Our next presenter is Damola Oluwademilola.
Yes, I'm here.
All right. Excellent. You can proceed.
So good evening once again, Stars and Ma. Good evening, everyone. My name once again is Daramola Oluwadimiola, 200 level student of Department of Medicine and Surgery, University of Ilorin, Nigeria. And today is my birthday, actually. And so it's so lovely that I get to present this on my birthday. So now let's get into it quickly. What's my reason for choosing this project? Now, number one, I am a preclinical student, and so I am not too familiar with the nitty-gritties of the word. I am not so familiar with how things actually occur, how the processes things take in the world. So I'm like, okay, why not identify um, something that is still related to healthcare, that is still in line with the theme, but among the students of this community. And that is what led to my topic, first aid and emergency response awareness at the University of Ilorin. Now, imagine you were students of the Faculty of Management Sciences, for example. Now, the Faculty of Management Sciences is like one of the farthest places on the permanent site campus. Now, it is really, really far from the school clinic. Imagine you were there and someone collapses, or you hear screams, you hear shouts, there is panic, there is confusion, and then you go to that place and you're like, okay, what is going on here? And then you see that, oh, someone was bitten by a snake, for example. Now, what comes to mind in that situation? There is a medical emergency that has happened because snake bite is an emergency, because if you don't attend to that quickly, it is going to become an issue. The person can even die, right? So you get to that place and then you see that the person was bitten by a snake, and then people, in the bid to try to help, they are moving the person up and down, they've tied the spots of that injury, they've done so many things, but there is no particular order. There is chaos in that kind of situation because there is no protocol. There is nothing that the students are able to follow in cases like that. So because of that, there is panic, there is confusion. Some people can even whip out their phones and begin to record because it's not like they do not want to help, but they do not know how to help, and this will lead to delayed care. Now, the problem, just at a glance. Now, there is no first aid training, no structured first aid training. I'm like, if I want to exaggerate, I would say like about 90% of the students on this campus cannot administer basic first aid. If someone faints, instead of people to allow the person to receive oxygen, like give the person space, removing all the things that may be occluding their airway and all of that, you see people gather. So it's like there is no first aid training, there is no basic knowledge of first aid. There are no signage or resources that show that okay, this is the place that if you encounter an emergency, this is the number you call, this is how to do it. If, in case you do not know how to do it, there is nothing like that. There is no peer culture, there is no normalized emergency readiness, response readiness amongst students, no campus protocol, there is bystander inaction, and this is the gap that this project wants to fix. Now, the STEP analysis. How does our first aid gap affect the quality of care on campus? It is not safe. That's the gap now. I'm talking about the gap now. It makes life on campus unsafe because medical emergencies can go unmanaged, and even situations where it shouldn't be much of an issue, it gets complicated, and then preventable harm occurs. Then it's not timely, there is delay in the response to situations, it's not effective because without training, bystander response is ineffective or harmful. Look at that situation now. Moving the person around will even help the venom to spread faster than it should. So it is very, very harmful to the patient. Then obviously it's not effective, it's not equitable. Why is this not equitable? Why does it make the healthcare on campus not equitable? This is the reason. Now, for somebody at the Faculty of Management Sciences, the person does not have as easy access to a healthcare facility or emergency response to someone that is at the teaching hospital campus. Because, okay,
that is closer to a hospital, like it's less than a stone throw away from the hospital. So there is that. So that makes it inequitable for the whole community. And then yes, patient centered. The victims are left helpless. Why? Because those around them lack the confidence to act. Now, our aim for this project is to increase the proportion of University of Ilorin students who can correctly identify at least 3 emergency response actions from less than 20% at baseline to at least 60% within 30 days through a peer-led first aid awareness campaign. So we have our what, our how much, our for whom, and by when. All of this is currently on the slide. Now, the Donabedian model, the current structure is that there are no structured first aid training, no visible emergency contact, there are no peer-led health emergency awareness. When we may say, oh, there is a Red Cross society, but based on my conversations with a lot of people have like a little bit of beam against them, probably because of how they behave at CBT Center. And okay. So the our intervention to this is that we're going to have awareness posters, WhatsApp campaign, and a demo session. The process is the percentage of students who can name at least 3+ emergency response steps, and they can actually do it, who know how to call for help on campus, who have ever practiced any first aid skill. And how are we going to measure this? We're going to do it by a pre and a post survey. Then the outcome is that there is going to be an increased emergency confidence among the students, and preventable harm is 100% going to be increased. So yeah, there's going to be there's going to be reduced preventable harm rather. Then change idea, basically, we're going to have an awareness demonstration, just 20 to 30 minutes session led by to a small sample size, probably a level in a particular department, and then it's going to be on how to do these things. We're going to do it by a trained, it's going to be led by a trained personnel, someone that is familiar with the ropes of this thing and can actually guide. Then we're going to have visual reminders at high traffic points, at eateries, in front of faculty buildings, at lecture theaters. We're going to have those things there so that in case something like that happens, even if you don't know what to do before, you can see that there is a guideline, there are steps on how to do it. And then we're going to have a WhatsApp group where we share tips, we share updates, and we share facts during this period. The PDSA cycle, our plan once again is to increase emergency medical knowledge from 20% to 60% in 30 days, and we're going to do it by awareness campaigns. And yes, so our prediction is that knowledge and confidence is going to rise at least to a certain extent after day one. Then from going to our do from week 1 to 3, we are going to have WhatsApp broadcast every 2 to 3 days so that we don't have like WhatsApp fatigue, people mute the group because our own is too much, something along those lines. So it's going to be very, very controlled to prevent the fatigue. Now we're going to have midpoint observations, check-ins, how are things, has any emergency happened, and you were able to step in and all those things. And then on the final day, we are going to have our final survey. We compile the results, and then we see, okay, what improved, what part was most impactful, and then if we find a good outcome, we are going to adopt it. If we do not, maybe partially effective, we're going to remodify and see how we can change or what we need to change and all those things. Then abandon it if there is no change. We redesign the whole thing entirely. What is our indicator? Once again, is the percentage of students who can correctly identify 3 or more emergency response and actually put them into use. And our secondary indicator is percentage of students who feel confident enough to respond in a campus emergency. We can compile that using a Google Forms and a Google spreadsheet. Now, our balancing measure, the side effects that we saw was that there could be anxiety or fear triggered by emergency scenarios. Like people could be shocked by, oh, this is something that can happen. Say a very graphic injury happening to someone, or a fracture, or all those things. So some people are not used to seeing things like that. So we collect how we're going to monitor is that we collect anonymous post-session feedbacks and make the tone
empowering. We're going to encourage them, and if they can't continue with it, of course, we're going to like allow them to do whatever they want to do, maybe leave or whatever. Then misinformation spread via WhatsApp. All the messages that we're going to be sending are going to be from verified sources, and we're going to categorically state it that this is the right information, and we're going to be debunking myths, or it's myths versus facts and stuff like that to reduce or prevent misinformation spread. Now, overconfidence, when you feel like you can do it, you want to be the hero, you want to be the hero, you want to be the one that is the person that saved the day, the superhero in that scenario. That is not what our project aims to encourage. Our project aims to encourage calling for help after giving the first response to that particular emergency. And then WhatsApp fatigue or disengagement, just like I have explained previously. Then using the Swiss cheese model, we have series of gaps that are currently in the emergency response system on this campus. And this our project aims to close these holes so that harm will not happen, so that preventable harm does not occur. So our project provides like a clear protocol. A clear protocol. This is who to call, this is how you do this, these are the steps to follow if you are in an emergency situation on campus. Now, just a quick tip or a little pause by a quote by Dr. Kolawole. He said, best clinicians treat the patients in front of them. The best leaders fix the system so that the next 1,000 patients are safer. Now imagine a campus where people know what to do in cases of emergencies. Imagine a campus where students are not screaming or shouting if someone faints, if a bone is fractured, if there is an injury. They know what to do, where to get help, and how to get this help. Now, this is the project at a glance. Our problem stated, aim statement, our indicator, change idea, PDSA cycle, and our balancing measure. Now, just a step further, taking this step further, we can now partner with, say, computer science students in their final year, or people that can program, develop an app that will have a centralized system. Like you click on the SOS, if there's a medical emergency, there's an SOS button you click on, and then it will track your GPS location and alert the nearest trained personnel on the campus. And then, they can be dispatch of the ambulance, and then the needed emergency care would get to the patient speedily. Then, yes, I think I have come to the end of the presentation. Thank you very, very much for listening.
Thank you for your.
Okay, wow, great job. As in, I love the fact that you took this one outside the hospital and you are looking at quality improvement even outside the hospital and not just limited to that. That's actually a smart move. At least it distinguishes your presentation, your project from every others, which makes it stand out in a good way. Then the confidence with which you present, I love it. Well done.
Thank you, ma'am. Thank you, ma'am.
Yeah, so acknowledging I'm in 200 level. I don't know so much of what happens in the clinic. That's a brilliant way to start presentation when you understand your limitations and you acknowledge them, and you don't see it as a negative for you. You are evolving. You will get there. You will get past it. Don't worry. Do you understand? You get past it. So. And you will do several other presentations at higher levels. Do you understand? But I think I appreciate your composure as well. You will be a good storyteller. If you improve on that skill, you will be a good yeah. So okay, happy birthday to you as well, right? Okay, so the only concern I have is you have taken the problem from a clinical problem to a public health problem, which is great. I'm on both sides, so it's not a negative for you. Most of our problems have been clinical, the ones we've been discussing. But looking at a public health problem increases the scale, the scope, also increases the kind of program evaluation that is required to even determine success. So it takes the success of it like far away from your outreach, kind of. Because now it's something that needs to be coordinated at the school level. That the VC has to know about it. They have to develop an application for, and maybe like a chip has to be on people's phone or an app or something, a scanner, something that can also dispatch an ambulance and another factor. So there are so many things in the ecosystem that has to be integrated together to make this work. So I appreciate your eye for seeing the problem, and I don't think it's even snake bite alone that should be the focus of a problem like this. Just imagine any other thing could happen in lecture theaters. People faint, people go into emotional breakdowns. When we're in 200 level and we're writing comprehensive exam, I remember one of our colleagues broke down, and when we're going to another level, I think another broke down. Stuffs like this could benefit from, and I see a lot happening across the distance across, and I know people have acute severe asthma. Different forms of this thing could benefit from a project like this. So it doesn't even have to be snake bite alone. That's where what I'm trying to communicate. So great job identifying a good problem, but it's a bigger problem. It's a public health problem, and it's not a problem for a PDSA to solve. Like I said, it's a problem that you need a full systemic analysis, and then a passionate leadership who is committed to ensuring that within the sphere of the University of Ilorin and the teaching hospital, I want to create a system that is safe and that can be digitally tracked, and that would make students safer. Even staff too would benefit from it, and all those things. And that has to be integrated with the healthcare system of the school. And I know the university has its own clinic, and then the teaching hospital has its own clinic as well. Of course, the teaching hospital itself. So these things has to be synced across board. All in all, great job. I know the network had dropped you off, but that's fine. Do we have one more presenter, right? Or is that all for today?
We have two more presenters, sir.
All right, please. Let's
Two. The next presenter is Mohammed Fatima.
My name is Mohammed Fatima Rola. I'm a current level medical student in University of Ilorin. And today I will be presenting my quality improvement project on improving hand hygiene compliance in the hospital through digital real-time dashboard. Now, this project of mine incorporates the three main ideas behind this project. This is quality healthcare, patient safety, and digital transformation. Healthcare associated infections remain a significant health challenge in our healthcare system worldwide. Now, hand washing, hand hygiene, which means the proper washing of our hands during the five critical moments, which is before touching a patient, before a cleaning procedure, after bodily exposure risk, and after touching the patient or after touching the patient's surroundings. In these five critical moments, WHO, it has been proven that hand washing in these five critical moments helps to curb, is an effective and the cheapest way of curbing this healthcare related infections. Now, healthcare workers are aware of the essence of this proper hand hygiene. However, they might not be able, like, compliance still remains low in our healthcare system because these healthcare workers on that they have high workload on their they have high workload, they might forget because of the shift, shift that they have. They have a lot of work on their hands. Sometimes, even if this hand washing is documented, it's usually documented using paper audits, and there's usually no feedback. Now, the problem, there's a visible gap between policy and practice. So once you look at these three main things, who is affected here and why does it matter? So in our healthcare system, the patients, the staff, and even the visitors are affected by this problem. If these three individuals do not undergo proper hand washing, then if one of them have an infection, for example, it could spread throughout the hospital from one ward to another. Where are we going to implement this project? Is a particular ward or a outpatient clinic that is selected throughout the 30 days. Why does this project matter? Now, we look at healthcare related infections as and we say that hand washing is very important in curbing this. So we want to increase hand washing compliance from the baseline, which is 55%, to at least 80%, which is the recommended WHO benchmark. Now, the statement. The aim statement for this project is to increase the proper hand washing compliance from 55% to 80% in 30 days. Now, increase hand washing compliance among clinical staff from at least, which is approximately 55% to at least 80% within 80 days using a digital real-time compliance dashboard. Now, this project is smart, it's specific, is measurable, it is achievable, it is relevant, and it is time-based. The indicator. How do we measure the progress of this project? How do we know that this project is efficient and it is sustainable? We are going to be using this particular formula, which is percentage compliance is equal to the observed hand hygiene actions with the clinical staff divided by the total Rule 5 moment opportunities that they get multiplied by 100. For example, in a particular word, maybe we have Mr. Hade now. Mr. Hade washes his hands maybe during his morning shift. In that particular day, we notice that he washes his hands about 60 times, and the total 5 moments that he got during that shift, that particular day, is about 100. We are going to say that percentage compliance for Mr. Ade is 60%. So now the change idea. How do we go about the entire thing? So we are going to be using a digital hand hygiene dashboard. We are going to have some observers, maybe a particular observer in a particular word who is going to like observe the healthcare personnel. You're going to look at them, how often they wash their hands. When he observes this, he, as the observer, is going to input this data into a computer using a simple mobile phone. And this simple mobile phone is immediately going to update a dashboard that is displayed somewhere where everyone can see. So this dashboard is color coded. We're going to be using three colors in this dashboard. We have the green, we have yellow, and we have red. Red is going to indicate a very poor performance, that is below 60%, and yellow indicates about 60 to 70%, which is also a good performance, but it needs improvement. And for the green means the best performance. That means we have reached the benchmark that we actually want to reach, which is above 80%. So this dashboard is going to replace the normal paper audit and is going to give us a visible feedback, immediate feedback. Now this project is going to be implemented over 30 days using two PDSA cycles. And the first cycle, we are going to in the first cycle, we are going to train the observers. We tell them what they are meant to do. So, and we collect the baseline data, we collect the data, we update our system, we read the trends, and then we look at places where we can improve. In the second PDHA cycle, that is the second 15 days, we are going to refine the tool. We look at places where we can improve, and also we consider our observations and recognize top indicators. This project is not going to be individual based. For example, maybe in a particular word, maybe we are going to have two teams. We are going to say, okay, team A and team B. So for team A, if they should perform very well, then we are going to recognize them and say, okay, particular maybe team A performs very well in this week's hand washing. Then we study, we compare the second cycle, we compare it to the first cycle, and we test for sustainability. We look at is it going to be efficient? Can we continue using it? If we notice that it is actually sustainable, then we can extend it to other wards in the hospital. balancing measures and expected results. While we are trying to solve a particular problem, which is the hand washing, we should make sure um as to not create more problems for ourselves. So in order to manage risk while doing
Good evening, everyone. Good evening, sir. Good evening, ma. Can you hear me?
Yes, please.
Okay.
Yes, we can
Um,
hear.
thank thank you very much, sir. My name is Sadiq Ahmed, and I'll be presenting a project on hand hygiene awareness during a clinical posting, a 30-day quality improvement project. And these are the outline I'll be using for my presentation. Healthcare-associated infections are considered as a major patient safety problem, and they are associated with prolonged hospital stays, increased healthcare costs, antimicrobial resistance, higher morbidity and mortality, as well as reduced quality of patient care. And poor hand hygiene has hello okay poor hand hygiene has been shown to contribute significantly to healthcare associated infections. Medical students have frequent patient contact during clinical posting, as they usually interact with the patient and also partake in the management of patients. Therefore, improving hand hygiene compliance can therefore reduce infection transmission. Informal observation has shown in the past inconsistent hand hygiene among medical students. Missed hand hygiene opportunities have also been shown to increase infection risk, and these are some of the contributing factors. That is, due to lack of awareness, busy clinical schedules, inadequate reminders have all been shown to contribute significantly to healthcare, to the development of healthcare associated infections, or to the transmission of infection within the clinical setting. The aim of my project is therefore to improve hand hygiene compliance among medical students from a baseline of 50% to 80% within 30 days. And this and my objectives include: one, assess the baseline compliance; then, secondly, to educate students, increase awareness using posters, encourage peer reminders, and evaluate improvements after intervention. That is, after the intervention, the project has been implemented, then I'm going to evaluate improvement after the intervention. So the participants for my project is going to be medical students. So it will comprise undergraduate medical students that are participating in clinical posting during the project period. These students, because the reason why it's going to involve medical students is because medical students basically interact they interact with patients and healthcare workers. They are making them an appropriate target group for the intervention in order to improve hand hygiene practices. My inclusion criteria for these medical students include that is, the medical students that are actively participating in clinical posting during the study period, students who provide consent to participate in the quality improvement project, students involved in direct patient care activities. And my exclusion criteria will include medical students absent during most of the intervention period, medical students not participating in clinical activities involving patient contact, also individuals who decline participation in the project. So data collection will be done using a standardized observation checklist that is developed by the WHO and hygiene. Compliance will be assessed by recording the number of hand hygiene opportunities observed and the number of times appropriate hand hygiene is performed. Observations will be conducted at baseline and periodically throughout the intervention in order to monitor the progress of the implementations of the project. Then the PDSA model will also be implemented. The duration of the project will be a 30 days period, and the setting will be clinical posting. The change idea I'll be implementing is to
combines several simple, low-cost, and evidence-based interventions that can be implemented within the existing clinical environment without disrupting routine patient care. This intervention will include hand hygiene education, that is, a brief interaction education section will be conducted in order to reinforce importance of hand hygiene, the mode of transmission of healthcare associated infections, as well as the WHO 5 movement for hand hygiene and the correct hand washing and hand rubbing techniques. Another change idea that will be implemented is visual reminders, that is, educational posters and reminder notices illustrating proper hand hygiene techniques, and the WHO 5 movement for hand hygiene will be displayed at strategic locations. And these strategic locations include ward entrances, hand washing stations, and treatment areas in order to serve as a continuous prompt for appropriate hand hygiene practices. The members of the project team will provide friendly reminders and encouragement to fellow medical students before ward rounds and clinical procedures, prompting mutual accountability and fostering a culture of patient safety. Another change idea that will be implemented is promotion of hand hygiene resources. That is, students will be encouraged to make consistent use of available hand washing facilities and alcohol-based hand sanitizers before and after contact with patients. There will be regular feedback will be provided to participants regarding observed hand hygiene compliance throughout the project. So the timeline for the project will be conducted within a period of 30 days, that is 4 weeks. And in the first week, this will include planning and baseline observation. That is, we'll first conduct preliminary planning meetings, obtain permission from relevant department authorities, develop the observation checklist, carry out baseline and hygiene observation, and also prepare educational materials such as posters and reminder notices. On the second week, we'll conduct a hand hygiene awareness section for medical students, display educational posters at strategic locations within the clinic, that is the clinic, the unit that will be used for the project will include the pediatric medical ward, the accident and emergency, that is the emergency unit for pediatric emergency unit, and as well as the pediatric surgical ward. So by the second week, we'll conduct a hand hygiene awareness section for medical students, display educational posters at those strategic locations within the ward, which include the pediatric medical ward and surgical ward, like I've mentioned earlier, as well as the accident and emergency unit. By the third week, we'll continue implementation of interventions, perform regular observations using the standardized checklist, provide a feedback to participants, and identify challenges affecting compliance. By the fourth week, we'll conduct final hand hygiene observations, compare post-intervention compliance with baseline findings, analyze the collected data, prepare the project reports, and present recommendation for sustaining the interventions. So these are the expected results for the project. So the first one, the expected result is compliance increase from 50% to 80%. That is after the implementation of the project. Before, as I've said earlier, the baseline assessment, that is the baseline assessment for the, according to WHO, that was noticed was that at least 50%, there's 50% there's 50% observation of hand washing within the clinical procedure. However, at the end of this project, the expected result is that there would have been an increase from 50% to 80%. Secondly, there will be better knowledge, that is, increased knowledge about hand hygiene and infection prevention. Then, thirdly, there will be improved patient safety, that is, safer care and better outcomes for patients. And the fourth expected result is reduced infection risk, That is, there will be fewer healthcare associated infections and complications. And finally, final expected result is improved infection prevention culture. So these are some of the possible challenges that might be experienced during the period of the project. The first is the limitation of time, because the project is to be done within a period of 30 time. The 30-day time might not be sufficient enough in order to carry out the whole project. Then second one is the busy schedule. That is, medical students are very busy going for their day-to-day activities. So this might also be a challenge during the project. Another one is observer bias. That is, the observers, those that will be observing the medical students, if they actually perform the hand hygiene, there may be some little biases or differences in their observation. And find also another challenge that may be encountered is the resource limitations. And these are my recommendation. That is regular awareness campaign, continuous audits, permanent posters to be placed in those strategic locations like I've mentioned, and also ensure that the what they are to use for hand hygiene is placed at the strategic locations where they will have access to them. In conclusion, hand hygiene is considered as the simplest, cheapest, and most effective way to prevent healthcare associated infections through education, reminders, monitoring, and continuous quality improvement. Medical students therefore can significantly improve hand hygiene compliance and they also contribute to safer patient care. Thank you very much. These are my references for my presentation.
Thank you, Ahmed, for the presentation. It seems quite a number of people are now looking into hand wash. It's actually a tricky terrain because I think there's a lot of paper, even probably projects out there that relates to that. I remember Dr. K also mentioned one of the studies that were done during I think maybe during an assessment where they were able to see that everything was there, but it was not done. So beyond the availability of what they need, another thing I'm worried about is continuous auditing is needed, yes, but won't it look like witch hunting people? And just like you also pointed out, bias too could be there in terms of measurement of who is adhering and or not. But overall, great presentation. I'm just a little bit worried about your topic, especially when you have quite a number of people with topics that are really standing out and are really hitting the nail on the. I'm not a medical person, so on that I may be wrong. So I'm not. It's not like that's the final. But overall, great presentation and referencing. Thank you.
Thank you very much, man.
Hello, can you hear me?
Yes, sir, I can hear you, sir.
Yeah, great presentation. Of course, hand hygiene is the intersection between clinical medicine and public health. You probably be the third person who has spoken about hand hygiene here, right? So, well, like she identified, it doesn't make your presentation less. It just makes it that we need to analyze the three of you the more. You understand? But it's an excellent. But I didn't catch what level you are.
Oh, I'm 500 level medical student, sir.
Unilorin, right?
Yes, sir. University of Illinois. Yes, sir.
Yeah, I didn't catch that. So, but that's the only thing. Yeah, but I'll review the slides and everything and the recording as well, and I'm sure appropriate decisions will be made. But please, I want you to know that you did a great job in communicating what you wanted to say. Thank you so much.
Thank you so much, sir. Thank you, sir.
Thank you so much for this wonderful section. As we
Good
bring
evening, sir.
this, Can you hear me? Good evening. Good evening. Who is that?
Yes, sir. It's more Fatima.
Okay.
I'm so sorry for
Are you
I'm
fully
so sorry
back?
for you. Yes, sir.
Yes, I understand. Okay, if
Yes,
I give you 2 minutes, we'll be able to wrap up.
sir.
Okay.
So we have to manage the risk while tracking the progress that we make with this project. So in order to manage the risk, so that we won't create more problems for ourselves, we make sure that this project, the increasing of the data is carried out under 10 minutes, under 10 seconds, sorry, and we rotate the observer rules. The workload is not just on one person, and also we report the results at team level rather than individual level in order to improve morale, and we also rely on existing devices and free spreadsheet tools to control costs. Now, the expected result is to increase the hand washing hygiene from 25% to 82%. Now, we have some, despite the benefits that this improvement might give us, we still have some challenges that it might come
Hello.
with. Yes,
Can
sir.
you be audible? You are giving a presentation.
Okay, okay. Sorry, sir. So, I identified two challenges that we might have with this project. The first one is digital illiteracy, especially in the rural areas. Not every medical personnel has the ability to like use a Google form or a spreadsheet or analyze a spreadsheet. They do not have the digital literacy to understand it. The second one is the limited device access. So in our healthcare system, we might not have the enough digital devices that we might use to input this data or even to show it um, show the spreadsheet. So we are going to solve these two problems by training the medical personnel. It's not going to take a lot of time. We train them on how to use the form, and we also make do with the existing devices that we have in the hospital. My conclusion and recommendation. So in conclusion, this project demonstrates that we can use a real-time digital dashboard to solve the problem of um, um, reduce compliance and hand washing in digital in our healthcare system. And my recommendations are that we hand over the dashboard ownership to the unit nurse manager or IPC lead, rotate the observer role to distribute workload and reduce bias, refresh reminders periodically to prevent fatigue or normalization, and scale the model to additional units following the successful pilot. Thank you very much for your time, sir. That's a must.
Thank you so much for wanting to finish, and I love the fact that you were able to finish strong. That shows your tenacity and the belief you have in your project. Well done.
Yes, ma'am. Thank you, ma'am.
Yeah, I'm still how are you, Fatima, right? I'm still struggling to get how
Yes,
the
sir.
data will be collated to the dashboard. Can you help me with that gap?
I didn't get your question, sir.
How would how would we connect the hand washing part activity to the dashboard? How will data get to the dashboard?
Okay, so what I explained was that we are going to have an observer in the ward who is going to like observe the medical personnel. He's going to look at or how many times they wash their hands. Then we are going to have a form, maybe a Google form, a simple Google form that can be filled with under 10 seconds. So it's going to input it into that Google form, and that Google form is going to be linked to a dashboard which can also update once it fills in that data.
Yeah, as long as it's dependent on human being, you already that's a flaw. I wish you're talking about an image recognition camera that can actually capture people's face as they're even washing and capture the whole process if they even do the washing well. And then Yeah, and be able to take the data and render it directly to the dashboard. But to recruit an extra human being, it usually wouldn't work in the long run. Yeah, but at least I appreciate your idea and what you're thinking about. Thank you so much. And the fact that you're passionate about hand hygiene as well. And I need you to know that what you have presented can also be extrapolated into other challenges. The only thing we need to remove is the fact that we need to recruit someone who will be filling a Google form or filling a form to update the data, the dashboard. If we can get that out of it, it will be an excellent intervention anywhere in the world. Is that okay?
Yes, sir. Thank you very much, sir.
You're welcome.
Thank you so much, sir. Thank you, Ma, for that wonderful comments. As we bring this presentation session to a close, I would like to express our appreciation to our wonderful CEOs, person of Dr. and Mrs. Kolawole, our lead administrator in Valdymas, person of Mrs. Olariwaju Folake, to their contributions to the success of this remarkable journey. Today marks not only the end of our presentation session, but also the successful completion of the first course of the free healthcare quality, patient safety, and digital transformation training for students, which started 20th of June. To all our presenters, congratulations. Over the past weeks, you have challenged yourself to think differently about healthcare, identify real-world problems, and develop practical, evidence-based solutions. Whether you are among the best 3 or not, remember that the greatest achievement is the knowledge, experience, and mindset you have gained. These are assets that no one can take away from you. Don't also forget that we have souvenirs and a certificate for all the participants. So the day the souvenir is going to be received by individual, I will definitely communicate on the group and also the certificate. To our distinguished judges, we sincerely appreciate your time, thoughtful evaluations, and constructive feedback. To everyone who joined, I want to appreciate Dr. Lucky from Delta State and Dr. Fuad from Lagos State. To others who joined us as audience member, thank you for your presence throughout both presentation sessions. As we conclude this quote, I encourage every participant not to allow today's presentation to become the end of your quality improvement journey. Instead, let this be the beginning. Although this quote is coming to an end, we sincerely hope this is not goodbye. We look forward to welcome you into future Valdymas Health programs, advanced training, and quality improvement initiative. And I will love to also encourage everyone to stay connected with Valdymas Health community. Stay connected on our Telegram, on our WhatsApp. There is what we call monthly webinar that we always do. So you always see us sharing it on the group. Always stay connected. It is free. So for you to gain more insights, more knowledge about it. And don't forget that our next course is coming up by September 12th. It's starting by 12th. So tell others that are unable to join this that they still have an opportunity to partake in our next course so that they can also be among the champions. Stay connected on our WhatsApp. We'll be dropping quiz where you can gain more knowledge. Whenever we share any flyers, ensure you share it on all of your social media areas so that others can also gain from whatever we are doing. Congratulations once again to every participant. for successful completing the first course. Have a wonderful evening. Thank you. Do you have anybody that have any question to ask before we call it a day?
Yeah, I want to ask, when will I get my prize if I'm the first position?
Okay, the price will be communicated on Tuesday. So you will be able to know the first position, the second, and the third by Tuesday. Do you have any other question? Dr. Lucky, do you have anything to say?
Well, no, to say. But they all did well, they tried, and they should keep up the good work. That's my own contribution.
Thank you. Thank you. That's our one of our ambassador in the healthcare quality patient safety and digital transformation program. Thank you, Dr. Lucky.
The other lady
Okay.
that Fatima, at least she tried, but the way she is presenting, it look as if, I don't know if she has done presentation aside maybe now, because the way she's presenting, even the other guy that presented that the 500 level, at least his speech is not. They tried. They should just keep up the good work. So long you people are on this great movement, at least you will get more insights and more enlightened. So I thank each and every one of you for participating on this great program. So tell others, tell your classmate and your colleague. That's all I have to say. Thank you.
Thank you so much, Dr. Lucky. And to the lady, just in support of the lady that actually presented, I think quite a number of them are even 200 level. So this might be like the first presentation for them. Of course, it can only get better from here, and I'm sure they must have taken some of the feedbacks to heart. It's not just about this presentation, even future presentation. Be audible, let people know that you let the passion. One of the things that made the Sofumi stand out last week was you can feel the passion of the presenter. It was palpable. So even from his voice, from his face, even every of his mannerism while presenting shows that he believes a lot about he believes in the project he's presenting. So a lot goes into presentation. Now, of course, we are all learning, but it can only get better from here. And I believe they've all taken the feedback to heart. There's a question that we need to address on the platform. Can someone participate in the second cohort even after participating in this one? Dr. K, you want to answer that?
Yes, that's exactly what I wanted to address, why I went to. So yes, you can. In fact, you are allowed to, even if you win in this one. You can still come again and then represent other ideas, other challenges that you see. So please, you're allowed to re-participate. And of course, on subsequent ones. Remember, for those in 200 level, you have many more opportunities along the line. So you're allowed to, please.
Do you have any other question?
Okay, so for those beyond those that would win the prize, remember I spoke about the ambassadorship this thing last week. If you're selected to be an ambassador, you would also be communicated with. There will be a letter to that effect to confirm your position and all the expectations that the organization will be looking forward to you satisfying or fulfilling to maintain the position, and maybe what advantage would come with that as well. So aside from that, if you win, just see it as there has to be a ranking of the presentation, and I don't want to say you're lucky because you're actually giving energy, you prepared, you understand, but it does what may make you win might be the strength of the problem you discovered. It might not mean that you presented well, and for some it might be excellent presentation. So it could be a mix of factors. That's where I'm going to. But don't and that doesn't mean that for those who would not win, as it were, maybe like in the first three position, don't feel bad like what you did wasn't exceptional. Please, I need you to believe in yourself and to note that you can always do well. I'm sure everyone will get a baseline item for whatever, for your participation, for your time. But one important thing that he has said, please stay connected, stay teachable, stay mentorable. If you keep reaching out, along the line there are more programs and more ideas that would come. You can, with your good passion, you can even be allowed to join the advanced training that is for professionals by the time you get to that level. So I can imagine you being 600 level now, doing well, participating well. By the time you become an house officer or a medical officer or a registrar, as it were, you would be allowed to participate in the professional training. And that's another level of training entirely. So please, I need you to stay connected and believe that either you want to specialize in public health and or quality improvement, or you even want to go fully into core clinical medicine or academia, you still need an excellent knowledge of healthcare quality, patient safety, and digital transformation. That is the world we live in now. And so hope to see the very best of you. Thank you so much for joining, and bye.
Thank you so much, sir. I want everybody to drop an emoji to appreciate our wonderful CEO for this great opportunity, to learn and to gain more knowledge about what you have been thinking before, the difference between what you know before and what you know now. Let us drop emoji to appreciate, because we know that we are still going to see more students to benefit from this. Thank you, everyone, and have a wonderful evening.
Thank you so much, sir. Thanks.
Thank you, thank you, thank you.
This is the shit.